Hi, I'm Hannah. I'm the Service Improvement Project Lead.
And hi, I'm Heather. I'm one of the clinical nurse consultants in the long-term follow-up program.
So the long-term follow-up program is a statewide program which operates in collaboration with the state's children's cancer centres at the Royal Children's and Monash Children's Hospital. We're a large mature service with approximately 900 active patients and have approximately 700 appointments per year. That makes our service in high demand. The purpose of the program is essentially to monitor for late effects, identify any potential complications from therapy, and to monitor for growth and development.
In the last 30 years, while the cancer death rate in children aged 0 to 14 years has decreased by about 60%, curing childhood cancer is not without consequences. So late effects is a relatively new and developing area of medicine. We provide surveillance and screening for our paediatric and adolescent patients, and we educate them on their health history and possible late effects to look out for, some of which are outlined here. Late effects are dependent on initial diagnosis, treatment, and individual circumstances. Some late effects of childhood cancer treatment we see commonly are scoliosis, dental abnormalities, learning difficulties, infertility, thyroid dysfunction, cardiomyopathy, and second malignancies.
So to address these needs, we've developed our model of care. We appreciate this is a busy slide and we'll deep dive into some of the key aspects of the model in this presentation. But in a nutshell, patients are typically referred to the program between 2 to 3 years after finishing their treatment following a period of cancer surveillance. Patients are triaged into risk-stratified multidisciplinary clinics to suit their individual needs and are generally seen 12 to 18 months following referral. We facilitate clinical assessments, tests and investigations and referrals as appropriate, and these are done in alignment with our newly developed statewide clinical practice guidelines. All long-term follow-up patients receive a treatment summary, roadmap of recommended tests and investigations and health information. Most of our patients have ongoing annual reviews, and then they follow a transition pathway that's also risk stratified that could include GP services or adult late effects.
We'll now take a more detailed look at some of the key components of our model of care. We developed our own pre-clinic questionnaire, which is usually sent to families 2 to 4 weeks prior to their appointment. The questionnaire gives families the opportunity to inform the long-term follow-up program about their needs, concerns, and identify any questions that they may have or would like discussed. AYAs are invited to complete the survey themselves. We currently use a survey platform called Lime Survey to share a link to the online survey. Our clinic coordinator exports these results and shares them with the team to facilitate pre-clinic meeting discussions. Approximately 50% of our patients return their surveys. This data is pretty basic, but it allows us to monitor the main difficulties, concerns of our families. From the slide, you can see 30% of PCQs returned highlighted a concern for school or work, 25 a concern for mood and behaviour, highlighting mental health challenges, and 24 a concern for fatigue, a very well-documented problem for childhood cancer survivors. This year, we'll be taking part in a project exploring the utility of validated tools in paediatric survivorship, which should yield some very interesting findings. The long-term follow-up program is a multidisciplinary service with clinics at Royal Children's and Monash Children's Hospital. We provide a face-to-face service for each patient, as each patient needs a physical assessment. Patients are risk stratified based on their diagnosis, treatment, and current requirements. There is a variety of clinic types and professionals within the program, including oncologist, endocrinologist, radiation oncologist, clinical nurse consultant, neuropsychologists, dietitians, social work, and physiotherapists. The program is based on a one-stop shop model where patients are seen by the relevant specialist during one visit. The consult will include discussion of education, activities, general health, medications, dental, immunisation, vision and hearing, along with health promotion and late effects education. For our AYA cohort, we offer time alone with medical consultant and CNC. Confidentiality and exclusion criteria is outlined. Tests and investigations are ordered at clinic once all needs are identified. This is determined based on individual diagnosis and treatment based on the Children's Oncology Group and our guidelines. These tests are followed up after clinic via telephone conversation or text message. We operate differently to acute services and wait till patients are reviewed before ordering tests, as the monitoring focus is now not on relapse or recurrence, but late effects monitoring and optimising growth and development management. Referrals made as required either into tertiary services or community, including recommendations such as mental health care plans, linking with community dietitians or local psychologists, are also discussed. This is becoming increasingly more challenging as we know community services are overwhelmed with long wait times. We'll discuss survivorship documentation on the next slide. Ultimately, our low-risk cohort will be discharged back into primary care when they turn 18, so we aim to establish good rapport with primary care to support integration back to community health. As previously mentioned, all families receive survivorship documentation. We provide a treatment summary which includes the child's diagnosis, dates, protocol, surgery, chemotherapy agents, including cumulative doses of anthracyclines and alkylating agents, radiation dosimetry, bone marrow transplant details, and any key events that have occurred during the patient's treatment. A copy is sent to the family, the GP, and any other health professionals involved in their care. This documentation is helpful to support shared care, transition, and also to help explain health history to young people who may not remember the details of their treatment. The treatment summary development is very resource labour intensive and often only as good as the data that is put into the medical record. There is also discrepancy across the sites in how they are developed, as at RCH it's developed into the medical records on Epic, but at Monash it's a Word document scanned into EMR. Our families do love this document, and it is great to have all the information in a very clear and concise form. In the future, we would hope to have our treatment summary on a digital navigator and for our families to receive this document at the end of treatment and not wait till they get to see us to get this valuable document. As a program, we focus on early intervention of late effects, so we also provide a roadmap to families and relevant healthcare professionals, which outlines the future plan of recommended tests and investigation. This is updated at each clinical review. The roadmap also aligns with our clinical practice guidelines and aims to help educate families and healthcare professionals about the reason for the investigation, the frequency, and the endpoint if there is one, and also outlines who is responsible for ordering the test. Our roadmap has recently been reviewed by consumers to ensure that it is user-friendly, which can be challenging as it essentially has two audiences, the patient and the GP or other healthcare professional.
In relation to shared care, we provide limited shared care through a GP telehealth model, which is approximately 3 to 5% of our encounters, where the patient attends the GP clinic and the consultant and CNC also telehealth into that consult to provide late effects education and support. However, as you can imagine, this is challenging to coordinate across services due to waiting times at both sites. In addition, some low-risk patients are seen by their GP in alternating years. As mentioned, we also work with our regional colleagues to help facilitate care closer to home where possible. We provide a shared care model in partnership with the Regional Outreach Shared Care Programme in Warrnambool, Albury, Shepperton, Bendigo, Ballarat and Geelong. Currently, there are approximately 150 LTF patients in the database that are eligible to be seen regionally. Following a recent service review, enhancing shared care is one of our main service improvement areas. We're interested in exploring the benefits and utility of nurse-led case conferencing without the patients present. We'd like to facilitate this with GPs and paediatricians to support their patients locally and provide key components of shared care, including providing a treatment history, guidelines, and clear communication channels back to the LTF programme. Transition is an important milestone for our families and will generally occur at 18 years of age. We aim to discuss transition plans early in the pathway, and this is supported by Time Alone from age 15 to help empower young people to manage their future healthcare. As you can see from the data on the slide, approximately 51% of our patients are transferred to GPs. So integrating back in with community health and establishing good rapport with local GPs is incredibly important, particularly as they may only ever see one childhood cancer survivor in their career. Therefore, we hope that the education and support provided resonates with patients and families and helps set them up for their future. 30% of our patients are transferred to tertiary hospitals for ongoing support for cancer and treatment-related late effects. Generally, these are patients who have had high-dose chemotherapy, radiotherapy, they may have had brain tumours or some solid tumours, a bone marrow transplant, or they may just have high complexity needs. Our most common referral pathways include the Peter Mac Cancer Centre Late Effects Programme, the Royal Melbourne and Alfred BMT services, and the Monash Haematology Survivorship Service. I think it's really important to note here that it can be challenging to find appropriate services for our patients, especially for our regional families.
In summary, the long-term follow-up program is a well-established and rapidly growing service.
Effective shared care in transition is crucial for improving experiences, ongoing engagement, and positive future outcomes.
We would love to hear from services about any shared care projects and community supports or potential local referral pathways for our AYA patients.
So here are our details. We also have a lot of online resources on the PICS website. So thank you for listening, and we are happy to answer any questions.